women with endometriosis in IVF treatments require more progesterone. So this is a very good paper which looked at optimal progesterone levels in endometriosis patients undergoing a hormone replacement therapy in a frozen embryo replacement. And the question is, do many women with endometriosis have a resistance to progesterone? And they were looking at a cutoff of progesterone of patients undergoing IVF treatment. A cohort of 262 patients in 179 endometriosis patients, 42 days of oral contraceptive pill, 5 days of washout, 6 milligram oral estrogen, vaginal gel as a luteal phase support, intramuscular progesterone 50 milligram daily. Embryo transfer was done on the 6th day of progesterone. Serum progesterone levels were done 9 to 11 days after embryo transfer. So if you look at the pregnancy rates, it was 60% positive pregnancy rate, 39% live birth rate, 34% pregnancy loss, and an optimal progesterone level of 118 nanomole per liter. So something much more important was that the live birth rate was 51% if the progesterone levels were more than 118, and the live birth rate was less than 34% if the progesterone levels were less than 18 nanomole a liter. So if you have a look at it, when was progesterone done? The progesterone was done 9 to 11 days after embryo transfer. So if you have a look at let's review this paper again. And if you look at the higher progesterone seems to have its benefit in endometriosis patients. And they claim that there may be a threshold for optimal serum progesterone. But remember, this is in contrast to other studies where lower progesterone levels were also associated with better outcomes. So what is the physiological explanation? The higher progesterone threshold may help to overcome a resistance to progesterone, and that is what we see in endometriosis, providing a physiological explanation. If you look at the conclusion, they feel that the optimal level of progesterone was 118 nanomole per liter, 37.1 nanogram per ml, resulted in significantly higher live birth rates. And they concluded that women with endometriosis in a frozen embryo cycle in a hormone replacement therapy may potentially benefit from giving a higher progesterone. What are the limitations of this paper? Single center study, heterogeneous population, and a very specific regimen was used. Now, why would there be low pregnancy rates? One is there's progesterone resistance at the level of the receptor, homeostasis imbalance with chronic inflammation, and an estrogen dominance. It means that even with a normal progesterone, the endometrium is not responding adequately to implantation. The hemostasis imbalance in the endometrium of endometriosis is associated with chronic infection. And this imbalance seems to affect implantation. So if you look at what the challenges that we face with endometriosis, there could be a possibility of a receptor level resistance, impaired progesterone signaling, inflammatory environment, and they conclude in that paper that if you do give progesterone, giving progesterone as a parenteral route, that is subcutaneous intramuscular and vaginal, and giving a higher range of progesterone may in fact give you a better live birth rate. But again, as studies progress, we may be able to give it a better idea.